Hello, my name is Patrick. I am currently doing my clinical rotation in emergency medicine. And while I was going through Rush Review and Smarty Pants, I decided to create how you'd practice questions that are specific to pulmonology. And I wanted to share it with you guys. Hopefully, this is helpful if you're preparing for your pants or if you're getting ready for your end of rotation exam. All right, this is not comprehensive, but I tried as much as I could to cover as many topics in pulmonology. So let's get started. Question number one: what is the most common cause of acute bronchiolitis? Again, what is the most common cause of acute bronchiolitis? The answer is respiratory syncytial virus, RSV. Okay, that's the answer. Question number two: how does a patient with acute bronchiolitis present? So when a patient has acute bronchiolitis, how does that patient present? You're going to see things like respiratory distress, expiratory wheezing, as well as tachypnea. Next question: how do you diagnose acute bronchiolitis? Okay, so you suspect that someone has acute bronchiolitis. How are you going to diagnose this? The answer is you're going to have to do nasal swab for respiratory syncytial culture to be able to do antigen assay. So the answer to that question is nasal swab. Next question: how do you treat acute bronchiolitis? So you know that this patient has acute bronchiolitis. You have done your diagnosis. How are you going to treat it? Okay. Treatment is mostly supportive. You want to make sure that the patient is sufficiently hydrated, make sure they are getting enough rest. I have also seen them give bronchodilators to relieve some of the symptoms. This may work, sometimes it may not do anything. You want to keep eye on saturation status. Okay, if these patients if they have oxygen saturation that is less than 95-96%, you want to hospitalize this patient. Also, it is important for you to know that the only treatment that has been shown to improve bronchiolitis is oxygen. Next question: what medication can be given prophylactically for bronchiolitis? Okay, what medication can be given prophylactically for bronchiolitis? Now, keep in mind there's no vaccination, but there's a medication that can be given, especially to those who are immunocompromised, to prophylactically target bronchiolitis. The answer is palivizumab. Okay, palivizumab, and this can be given once per month for 5 months. Like I mentioned before, this is especially beneficial to those who are immunocompromised and premature infants. Again, there's no vaccination for bronchiolitis. Next question: what is the most common cause of bronchitis? Okay, so we've covered bronchiolitis. Now we're talking about bronchitis. What is the most common cause of acute bronchitis? Okay, and how is the patient going to present? The answer is viral. Okay, the most common cause of acute bronchitis is viral. It accounts for about 95% of the cases. Now, the second most common cause, bacterial, is M. catarrhalis. Okay, that is the second most common cause, or the most common cause bacteria. The most common bacterial cause of acute bronchitis. In terms of how the patient is going to present, you are there will be cough for typically more than 5 days with clear sputum, and you could have fever and other constitutional symptoms such as headache and malaise. Next question, how do you diagnose acute bronchitis? Okay, how do you diagnose acute bronchitis? I'm going to give you a few seconds to see if you can figure that out. All right, diagnosis for acute bronchitis is clinical. Okay, so you put the symptoms and everything that's going on in terms of history and physical, you make the diagnosis clinically. If you are not certain, you can do chest x-ray. Okay, so when in doubt, you want to do chest x-ray, but the diagnosis is clinically done. Next question, how do you treat acute bronchitis? So again, you've made your clinical diagnosis that the patient has acute bronchitis. How do you treat it? So treatment is mainly supportive and making sure that you're addressing the symptoms that the patient presented with. You want to make sure that they're getting enough fluid, getting enough rest, and you could give anti-cough medication to address cough. Next question, when can you consider giving antibiotics to patients who have acute bronchitis? Okay, when is it appropriate for you to give antibiotics to patients with acute bronchitis? So patients who have multiple comorbidities such as COPD, CHF, or elderly people who's the more we get older, the more the strength of our immunity dwindles. Okay, so those are people in whom you can give antibiotics if they have acute bronchitis. And the most common antibiotics that are used are azithromycin or clarithromycin. Next question. So you have a patient who suddenly develops fever, and there's dysphagia, drooling, as well as respiratory distress. And you also notice that the patient is sitting in a tripod position. So they are sitting and leaning forward, and there's muffled voice. What is the most likely diagnosis? Okay, so let's go through this question again. This patient has sudden fever. They're struggling. There's difficulty swallowing. That's dysphagia. They're drooling. And there's respiratory distress. So there are 3 Ds here. And you also notice there's muffled voice. What is the likely diagnosis? The answer is acute epiglottitis. Okay, that's acute that's acute epiglottitis. Again, there are 3 Ds that you want to remember with this disease. You want to remember drooling. You want to remember dysphagia. You want to remember distress. And epiglottitis is inflammation of the epiglottis and obstruction of the airway due to infection. And this is a clinical emergency. Next question. What is the most common cause of epiglottitis in a patient who is not vaccinated? Okay, this is a very important question. I actually had this question when I was doing my pediatric rotation. So what is the most common cause of epiglottitis if the patient is not vaccinated? The answer is Haemophilus influenza type B. Okay, type B. There are other types, but specifically type B. Now, interestingly, the question said in a patient that is not vaccinated. What about patient that is vaccinated? What is the most common cause of epiglottitis in a patient who is vaccinated? The answer is strep pneumonia and Staph aureus. Okay, so you want to really make that distinction because sometimes they can set you up with these questions. Next question, how do you diagnose epiglottitis? And I'm sorry, I made a mistake here. But how do you diagnose epiglottitis and what would you see? That's what this question should read. Okay, how do you diagnose it and what would you see? So you do lateral neck x-ray. Okay, that's what you want to do. You want to do a lateral neck x-ray. And when you do the x-ray, you're going to see thumbprint sign. And this is due to swelling of the epiglottis. Okay, so you get a lateral neck x-ray. And when you review the x-ray, you're going to see thumbprint sign. Okay, and you want to keep in mind that laryngoscopy is the definitive diagnosis. And when you do laryngoscopy, you could see edema or cherry red epiglottis. That is diagnostic. Next question, how do you treat epiglottitis? So you know this patient has epiglottitis, you've done your diagnosis, and now it is treatment time. So how do you treat it? You treat this by first making sure that you secure the airways. Okay? And you do this by intubating the patient. So it's really important that you secure the airway. Okay? And then you administer ceftriaxone. Now, this might change depending on the age of the patient. Okay? But typically, you administer ceftriaxone. Next question. You have a patient who had knee replacement. And this patient pretty much has been immobile for 2 weeks. And they started complaining of chest pain. Heart rate is 110 beats per minute. Respiratory rate is 40. And you notice jugular venous distension as well as dyspnea. What is the most likely diagnosis? So again, this patient had a major surgery done. And since they had this surgery, they've been immobile. They haven't been able to move for 2 weeks. And subsequently, they started complaining of chest pain. And you check the heart rate, it is 110 beats per minute. Respiratory rate is 40. And you also see jugular venous distension. Okay? Question is, what is going on with this patient? What do they have? This is pulmonary embolism. And what it is it is the blockage of one of the pulmonary arteries in the lungs. Okay? So when one of those pulmonary arteries is blocked, that could lead to pulmonary embolism. And 90% of the clot originate, okay, from the deep veins in the lower extremities. Next question, what is the most common symptom of pulmonary embolism and what is the most common sign of pulmonary embolism? So, what is the most common symptom of PE and what is the most common sign of pulmonary embolism? So dyspnea, which is difficulty breathing, is the most common symptom. Tachypnea, which is rapid breathing, is the most common sign. Okay, dyspnea, which is difficulty breathing, is the most common symptom of pulmonary embolism. Tachypnea is the most common sign of pulmonary embolism. Other things that you're likely going to see, you might see chest pain and as well as hemoptysis. All right, next question. Name 3 risk factors for pulmonary embolism. Okay, and what criteria is used, or what score can you use to evaluate the probability of pulmonary embolism? So in terms of risk factors, you want to remember your virtuous triad, and that includes hypercoagulable state, venostasis, as well as endothelial injury. And that is known as the virtuous triad. And the score that you can use to determine the probability of someone having pulmonary embolism, that is known as Wells criteria or Wells score. Next question, what is the gold standard definitive diagnosis for pulmonary embolism? Okay, and this is important in medicine. Sometimes you have the gold standard. It may not be readily available. It may be more invasive, but then you have initial diagnosis. It may not be the best, but sometimes it may be the most common, right? The one that is mostly available. But this question is asking what is the definitive diagnosis, the gold standard of pulmonary embolism. The answer to that is pulmonary CT angiography. So like I mentioned before, when you suspect that patient has pulmonary embolism, you can start with spiral CT. But the gold standard is pulmonary angiography. All right, next question. If you do a chest x-ray in someone in whom you suspect pulmonary embolism, what will it show? Typically, the chest x-ray is normal, but you could see Westermarck sign, or you could see Hampton hump. Next question. When is VQ scan preferred over CT scan for pulmonary embolism? And the next question is, what type of mismatch would you see? So you're going to do VQ scan over CT if the patient has contrast allergy or if the patient is pregnant. In terms of the mismatch that you're going to see mismatch in perfusion, but there will be normal ventilation. Okay, so with pulmonary embolism, the pulmonary artery, one of the pulmonary artery is blocked. They are not getting perfused adequately. So there will be a mismatch in perfusion, but ventilation will be fine. Next question, what is the most helpful EKG finding in a patient who has pulmonary embolism? So what is the most helpful finding in EKG of someone who has pulmonary embolism? And what is a rare but specific EKG finding in someone who has pulmonary embolism? One is most helpful, the other one is more specific, but it's not common. Let's find out. So the answer is inverted T waves in precordial leads. So if you see this, it's very helpful. Okay. The answer to the second question is S1Q3T3. People who have patients with pulmonary embolism, about 20% of those patients, you're going to see the S1Q3T3. But again, this is not very common. Okay, but when you see it, it's very specific to PE. All right, next question. What is the treatment of acute pulmonary embolism? What is the treatment of acute pulmonary embolism? And the answer is heparin. Heparin is your antithrombin. Next question: when you see, when do you use, so sorry about this, but the question is, when do you use unfractionated heparin in a patient with PE? So unfractionated heparin is good for patients who have kidney problem, or patients who are critically ill, or patients who need surgery, or whenever you're worried about bleeding concern. So unfractionated heparin it's a good choice. Which patients are considered candidates for thrombolytic therapy? Okay, patients with pulmonary embolism that are good candidates for thrombolytic therapy. Those patients are patients who are hemodynamically unstable. Okay. So the patients who are hemodynamically unstable, they are good candidates for thrombolytic therapy. An example of thrombolytic therapy that you can use are streptokinase, alteplase, or urokinase. Now, if patient is hemodynamically unstable, thrombolytic therapy is contraindicated. In that case, you want to do embolectomy instead of thrombolytic therapy. Okay, so it's important for you to remember that. Next question: what medications are used after acute management of pulmonary embolism? So for acute management, you use heparin, but then after that, what do you want to use? You want to use factor X inhibitors. Okay, factor X inhibitors. That's the next thing you want to use. An example of those, you can use things like rivaroxaban and apixaban, edoxaban. Okay, or you can use oral direct thrombin inhibitors. Okay, and make sure this patient, depending the guideline, depending on what your source is, the guideline may be different, but you want to keep them on this medication for at least 3 months. Next question: when do you use warfarin? Okay, when do you use warfarin for patients who have pulmonary embolism? You use warfarin when factor X or the direct thrombin inhibitors that I previously mentioned, when those guys are not available, you want to use heparin. Okay, and you also you want to use warfarin. Sorry, you also use warfarin with patients who have severe renal insufficiency, and the target INR that you want to watch out for is between 2 and 3. So I also saw this question when I was doing my practice questions, and the question is, when do you use IVC filter? Okay, you use that. You use IVC filter when anticoagulation is contraindicated. Example, when there's a severe GI bleed. Next question: what is the first line anticoagulation therapy for patient who has PE and cancer? Okay, this is commonly tested. So patient has pulmonary embolism as well as cancer. What anticoagulation would you use? So in this case, you want to use low molecular weight heparin, such as enoxaparin or dalteparin. Okay, so you remember that. That's a very important question. Next question, what are the complications of pulmonary embolism? Okay, this is one of the big boys, especially when someone comes, you know how it goes in the emergency room. Your priority is to rule out what is likely to kill the patient. Okay, so pulmonary embolism is one of those that you need to do your due diligence. Make sure you don't miss this. Okay, because there are lethal complications or consequences that could arise if you misdiagnose pulmonary embolism. So complications could lead, you can have right ventricular failure, you can have ischemia, you can have cardiogenic shock, you can have syncope, okay? You can as well ultimately have death. So someone can die from pulmonary embolism. Next question, patient has fever around 102.5. They have chills, they have headache, they have coryza, which is runny nose. They are complaining of myalgia, which is muscle pain, and malaise. What is the most likely diagnosis? The answer is influenza, commonly known as flu. So what causes influenza? This is caused by orthomyxovirus. Orthomyxovirus. Okay? And there are 3 strands of the flu. You have type A, which is most severe. You have B and C. At what age should flu vaccine begin? Okay, this is very important. When should you start administering flu vaccine? Who should avoid flu vaccine? Should pregnant women get flu vaccine? Let's find out. So, you want to start administering flu vaccine if patient is 6 months or older. Now, who should avoid flu vaccine? Patients who have egg allergy, gelatin, or thimerosal allergies. I don't know if I'm saying that right. If a patient has Guillain-Barré syndrome, they should also avoid flu vaccine. Okay, so people who have who had bad reactions in the past after getting the flu shot, they might want to stay away from getting a flu vaccine. This is a commonly tested question. Should pregnant women get flu vaccine? The answer is yes. Flu vaccine is safe for pregnant women. However, they should not get the live attenuated vaccine or the nasal spray. Okay, so anything live vaccine, you don't want to give it to pregnant women. Next question, how do you diagnose someone with flu? And how do you treat it? What medications can you give? And when is this medication most effective? So you want to do your rapid antigen test. That's usually done in the clinic. But rapid serology test is more accurate. And usually when you obtain a chest x-ray, you will see bilateral diffuse infiltrates. And how do you treat flu? It's really mostly symptomatic. Okay? You address the symptoms that the patient is presenting with. Or you can do antivirals, such as Tamiflu. Okay? And ideally, you want to administer this medication in less than 48 hours. Okay? So it is ideal. If it's more than 48 hours, it's probably not going to do anything for you. Okay? So someone comes in, they've had flu for, more than 48 hours. This medication is probably not going to do much. So ideally, you want to administer this medication in less than 48 hours after someone developed flu. All right, which population should receive these antivirals? Okay, and which antivirals only treat influenza type A? What medication should be avoided in patients with influenza? So hospitalized patients or immunocompromised patients or patients with chronic medical conditions or patients who are 65 years and above, they should get the antiviral, okay? The antiviral that mostly target influenza A is amantadine as well as rimantadine. For those who have flu, it is important that you avoid salicylate because this can cause something that is known as Ray's syndrome, especially for patients who are below 18. Next question, you have a patient who is 40-year-old. They're presenting with fatigue, productive cough, night sweats, weight loss, and fever. Chest X-ray shows cavitary lesions at the upper lobe. What is the most likely diagnosis? How is this transmitted? What organism causes this? So this is tuberculosis, and it's transmitted by inhalation of airborne droplets. So when someone with TB coughs and they sneeze and you inhale it, that's how you get it. Okay, it's commonly caused by Mycobacterium TB. That is the acid-fast bacilli. Next question, what are the risk factors for TB? How do you screen for TB? What should you see on chest X-ray of someone with active TB? What would the biopsy show? So let's start with the risk factors. So the risk factors are immunocompromised, such as someone with HIV or someone coming from an area where TB is common, or recent immigrants, or prisoners, or those who work in the healthcare. Okay. How do you screen? You can do tuberculin skin test, which is also known as PPD, or you can do interferon gamma release assays. What you're likely going to see on the chest X-ray, you're going to see cavitary lesion in the upper lung, and you can see infiltrates. You can see gone complexes in the apex of the lungs. And if you happen to do a biopsy, you will see caseating granulomas. Next question, what induration confirms a positive tuberculin skin test? This is a very important question. So for those who are high risk patients, or patients, you look at their chest X-ray and you see fibrotic growth, okay, or fibrotic changes, sorry, or patients who, like I said before, that are immunocompromised. They can have HIV, or they use steroids on a daily basis, or people who have come in contact with patients who are infected with TB. So the induration you're looking at is greater than 5 millimeter. The next group of patients are patients who are, and I had to learn this recently, if a patient is less than 4 years old, or patients who work who are healthcare workers, or IV drug use, or immigrants from high prevalent areas, or prisoners, or people with diabetes, or people who are homeless, the induration that will be considered positive is greater than 10 millimeters. Then you have the third group, which that group includes healthy patients with no risk factors. So they get a lot of leeway. They get the most freedom. Okay. the in duration is greater than 15 millimeters. Next question, what is miliary TB? Okay, very important question. What is miliary TB? And if PPD or IGRA is positive, what do you want to do next? And what is Pott's disease and scrofula? All right, let's find out. Miliary TB is when TB spreads outside of the lungs. So typically TB is it's a disease of the lung, right? It happens in the lung most of the time, predominantly. But sometimes it can spread outside of the lungs, and that is known as miliary tuberculosis. Okay, Pott's disease is TB that has invaded the vertebral column. Scrofula is TB of the cervical lymph node. Next question, what is the difference between latent and active TB? And how do you treat latent TB? Latent TB has positive PPD or IGRA, but chest X-ray is negative and they are not infectious. On the other hand, active TB has positive PPD or IGRA, and when you look at the chest X-ray, it is positive. And these people are infectious. Now, latent TB can be treated with once weekly isoniazid plus rifampin for 3 months, or you can do rifampin daily for 4 months, or you can do daily isoniazid plus rifampin for 3 months. Now, how do you treat active TB? You treat active TB, you do a 4-month rifampin and moxifloxacin regimen, or you can do 6 or 9-month regimen, which comprises quadruple therapy known as RIPE. And that includes your rifampin, which causes orange color pea. And it also includes isoniazid, which causes peripheral neuropathy. It also includes pyrazinamide, which causes hyperuricemia. And it also includes ethambutol, which causes optic neuritis. Okay, you really want to get this down. This is very important. They always ask these questions, especially the side effects of tuberculosis medication. You will always see it, I guarantee you. All right, next question. What medication must you give whenever you give isoniazid to prevent peripheral neuropathy? What do these drugs have in common, and what lab must you obtain? Why do some patients have false positive TB skin test? And what test can be used to address this? This is a very critical question. That is a very critical question. What medication must you give when you give isoniazid? Okay, let's find out. You must give vitamin B6, 25 milligram to 50 milligram per day to prevent peripheral neuropathy. And TB drugs, what they have in common is that they are all hepatotoxic, and you must obtain a baseline lab to check liver function. And I had this question specifically. So patients who previously got BCG vaccination, like patients, a lot of people from Africa, for example, they are vaccinated with BCG. Okay, and because of that, when you do their skin test for TB, you tend to get false positive. Now, how do you tell if this person is reacting to the BCG vaccine or if they actually have TB? You do a blood test known as IGRA, because the IGRA blood test is not affected by prior BCG vaccination. Next question, to stop treatment. So someone has active TB and you're giving them therapy. In order for you to stop the treatment, how many negative cultures would they have to return? What is used for definitive diagnosis of TB? What is the proper time to read PPD or skin test? So these patients that are under therapy, they have to return. They have to return 2 negative acid-fast bacilli smears and cultures in a row for you to stop treatment. Okay, and you diagnose TB with sputum for acid-fast bacilli smears and cultures. All right, in terms of what is the time frame for you to read the skin test, that should be done within 48 to 72 hours. Okay. Next question, a 60-year-old patient who has smoked for 30 years presents with weight loss for 3 months and has noticed streaks of blood in the sputum. PE shows coarse rhonchi and wheezing over both lungs, and he is thin appearing and anemic. What is the most likely diagnosis? So this patient is 60 years old. They've been smoking for 30 years. They had weight loss for 3 months, and you noticed streaks of blood in the sputum. What is this telling you? This patient has lung cancer. Next question, what are the 2 main categories of lung cancer? Which type of lung cancer is most common? Name 4 types of non-small cell lung cancer. Okay, the 2 categories are small cell lung cancer as well as non-small cell lung cancer. The non-small cell is the most common. It represents about 85% of the cases. And adenocarcinoma, it's the most common type of non-small cell lung cancer. Okay. So in terms of non-small cell lung cancer, again, you have adenocarcinoma, you have squamous cell carcinoma, you have large cell, and you have carcinoid tumor. Next question, which types of lung cancer are centrally located and associated with smoking? How do you diagnose lung cancer? If you do biopsy, what would you see? All right, squamous cell and small cell lung cancer are centrally located and they are associated with smoking. Small cell is not amenable to surgical resection and it metastasizes very fast. Okay, in terms of diagnosis, you want to do is chest X-ray, CT scan, as well as biopsy. And what you're going to see when you do the testing, you will see an ill-defined lobar or spiculated lesion, and that is suggestive of cancer. And if nodule is less than 1 cm or shows calcification, or it is smooth and well-defined edges, that is benign. So in that patient, you want to monitor these patients at 3 months, 6 months, and then every year for 2 years. All right, what is the difference between a nodule and a mass? What type of lung cancer develops peripherally in the bronchioles and has link to smoking? And what type of lung cancer is found throughout the lungs, but both centrally and peripherally? Okay, so the difference between a nodule and a mass is nodule is less than 3 cm and mass is greater than 3 cm. Second question, adenocarcinoma has no link to smoking and is mostly peripheral. The one with link to smoking is small cell cancer. And then the last question is what type of lung cancer is found throughout the lungs, and it's both central and peripheral. That is large cell carcinoma. Next question, what is the treatment of small cell lung cancer? And what is a low-grade malignancy of neuroendocrine cells, and it has stem cell origin as small cell carcinoma? Which lung cancer is commonly associated with ectopic ADH secretion and hence SIADH? So the treatment of small cell is chemotherapy. And the cancer that has a low-grade malignancy of neuroendocrine cells, that is carcinoid tumor. Okay, that is carcinoid tumor. The cancer that is associated with ectopic ADH secretion and SIADH, that is small cell lung cancer. And in this type of cancer, you are likely going to see hyponatremia. It is a common question that they ask. Next question, what type of cancer is commonly associated with paraneoplastic ACTH secretion? What is the most common carcinogen associated with small cell, squamous cell, as well as large cell carcinoma? And then what is the treatment of non-small cell lung cancer? So let's start with the first one. What type of cancer is commonly associated with paraneoplastic secretion? And that is small cell lung cancer. The carcinogen that is common with small cell, squamous cell, as well as large cell carcinoma, that is smoking. All right. And then the last question, what is the treatment of non-small cell cancer? That is surgery. Remember, small cell, you don't want to do surgery. It's not going to help you. Okay. Large cell or non-small cell, you want to do surgery. Now, there are 3 stages here. If it's within stage 1 to 2, you do surgery. If they're in stage 3, you want to do chemo plus surgery. And then stage 4 is just palliative. All right, next question. What is the most primary lung cancer in non-smokers? And name the epidermal growth factor used in treating non-small lung carcinoma. And dash is bronchogenic tumor with superior sulcus involvement and Horner syndrome. So what is the most common primary lung cancer in non-smokers? That is adenocarcinoma. And question number 2, name the epidermal growth factor used in treating non-small lung carcinoma. That is, I struggle to pronounce this, but that is erlotinib, and it's a thyroxine kinase inhibitor. And the next question is, dash is a bronchogenic tumor with superior sulcus involvement and Horner syndrome. That is a Pancoast tumor, and that is most likely squamous cell and adenocarcinoma. This type of tumor, they compress the nerves and blood vessels in the upper region of the lungs. How does Pancoast syndrome present? What is Horner syndrome? What is carcinoid syndrome? So Pancoast tumor, you're going to have shoulder pain, Horner syndrome, plus bony destruction. Okay, so the next question is, what is Horner syndrome? That is excess constriction of the pupil of the eye, which we call miosis. You could also have ptosis, which is drooping of the eyelid, and you could have anhidrosis, which is inability to sweat normally. And the third question is, what is carcinoid syndrome? Carcinoid syndrome is specific to carcinoid tumors and is caused by release of serotonin, and that increases peristalsis, diarrhea, and bronchoconstriction, causing asthma. Okay, they always test that question. Next question, what is carcinoid tumor? How is lung cancer often initially identified on chest x-ray? And then the next question is, once an abnormal lesion has been identified on chest x-ray or CT scan, what is the next step? Okay. So what is a carcinoid tumor? It's a GI tract cancer that metastasizes to the lungs. It presents with hemoptysis, cough, focal wheezing, and pneumonia. Sorry, I spelled that wrong. Next question is, how is lung cancer often initially identified on chest x-ray? You're likely going to see what we call a coin lesion on chest x-ray, or you can see non-calcified nodule on chest CT scan. Okay. And the next question, once an abnormal lesion has been identified on chest x-ray, what do you do next? You want to biopsy. Okay. That's a very good thing to remember. Next question, 2-year-old girl was playing with her brother in the living room and suddenly started choking, gagging, and wheezing after playing with his brother. PE shows decreased breath sounds, inspiratory stridor, as well as expiratory wheezing. What is the most likely diagnosis? This is foreign body aspiration. Okay, so that is a foreign body aspiration. This happens when foreign bodies such as coin, or it can even be popcorn, or food enters into the airway and causes this patient to choke. So where does aspirated foreign bodies lodge? What are the most common aspirated foreign bodies? So most foreign bodies are going to go to the right main bronchus. That is 80% of the time. Okay. And in kids, the most common, it's peanuts. Then can also have like seeds, popcorn, hardware, or when they're playing with pieces of their toys. In adults, especially psych patients, they tend to aspirate or swallow pins and nails. Okay. Then it can be various foods. What are the signs and symptoms of foreign body aspiration? Okay, what are the signs and symptoms of foreign body aspiration? What initial diagnostic test is used for foreign body aspiration? What is the procedure of choice to identify and remove the foreign body? You're likely going to see decreased breath sounds, wheezing, violent cough, stridor, inspiratory stridor if it is high in the airway, or you can see wheezing and decreased breath sounds if it is low in the airway. And you want to do chest x-ray, and you're likely going to see hyperinflation. In terms of diagnosis, diagnostic test of choice is bronchoscopy. In kids, you want to do rigid bronchoscopy. In adults, you want to do flexible. All right, next question. I'm getting tired, guys. Next question. When is surgical removal indicated for foreign body? What are the risk factors for foreign body aspiration? So surgery is done when bronchoscopy does not help. And then the risk factors for foreign body are institutionalization, advanced age, poor dentition, alcohol, and sedative use. Okay. Next question, you have a 4-year-old boy who came to the emergency at midnight presenting with cough, chest pain, shortness of breath, physical exam. He is sitting in a tripod position. breathing deeply and slowly to catch his breath and speaking in short sentences. You hear prolonged expiratory wheezing. He has a history of eczema and seasonal rhinitis. What do you suspect this is? And this is asthma. It is a chronic, reversible inflammatory airway disease with recurrent attacks. Next, what is the most common cause of asthma? What is the most important triggering factor for asthma? What cells appear to play a role in activation of inflammatory response in asthma? So, the most common cause is exposure to allergen. And then the factor that triggers this the most important triggering factor is upper respiratory infection. And the cell that plays role in inflammation in patients with asthma is Th2 cells. That's the CD4 T cell. Next question, what are the symptoms of asthma? What are the symptoms of asthma? What is the initial diagnostic test for asthma? What makes asthma reversible compared to COPD? So in terms of symptoms, you see cough, wheezing, chest pain or chest tightness. You see there will be shortness of breath, and can also be increased mucus production. Tests you want to do for asthma, you want to do pulmonary function tests such as spirometry. Okay, what makes asthma reversible is that you will see increase in FEV1 of greater than 12% with a minimum increase of 200 ml in FEV1 after you administer bronchodilator. Okay. You suspect the patient has asthma, but you do a pulmonary function test like spirometry and it's normal. What are you going to do? What are the classifications of asthma? So someone has asthma, but spirometry is normal. You want to bronchoprovocate this patient with something called methacholine, and you're going to see positive. This test will be positive if FEV1 decreases by 20%. In terms of classifications of asthma, you have intermittent asthma, which the way I remember this, because there are so many things that can happen, but the distinction is that there will be less than 2 nights awakening per month. And then the second classification is mild persistent, where you have 3 to 4 nighttime awakenings per month. And you can have moderate persistent, where you have greater than 1 nighttime awakenings per week. And you have severe persistent, where you have nighttime awakening 7 times a day. And next, how do you treat asthma? Before adding additional medication to someone who has asthma, what should you ensure first? So for mild intermittent asthma, you use SABA, which is your short-acting beta agonist. You use that as needed. That's, albuterol. For mild persistent, you can add low-dose inhaled corticosteroid daily. For moderate persistent asthma, you can add low or medium dose inhaled corticosteroid plus LABA, which is your long-acting. Okay. Then for severe persistent, you want to do high-dose inhaled corticosteroid plus long-acting with or without oral steroids. And then for acute attacks, so someone comes in the emergency, they have acute asthma attack, you want to do nebulized SABA, Atrovent, and oral steroid. That's the triple treatment. And then before you add medication, make sure they are using their inhaler correctly. Okay, make sure they're using their spacer, or if they have a pump, make sure they're using them correctly, because you can prescribe all this medication, but if they're not using them correctly, it's of no use. I'm getting tired, guys. What are the three main pathophysiology of asthma? And next question, define status asthmaticus. So the pathophysiology is 1, there's airway hypersensitivity. 2, there's bronchoconstriction. So there's narrowing of the airway. These people make a lot of mucus secretion. You can have edema or swelling of the bronchial wall, and there could be remodeling as well. And the third one is inflammation, and that's why we give steroids, because it addresses the inflammatory aspect of asthma. In terms of status asthmaticus, this is a severe life-threatening asthma attack that is refractory to normal treatment. So you've done all these things and it's still happening, and it's very severe, and this can lead to failure of the respiratory system. How do you manage status asthmaticus? And what asthma triggers do you need to be aware of? And this is the last one. So in terms of management of status asthmaticus, you want to administer oxygen, give bronchodilators, give systemic steroids, and then you can begin to consider things like magnesium sulfate, ketamine, as well as epinephrine. In terms of asthma triggers that you really need to be aware of, because the thing with asthma is if you really pay attention to those things that trigger your asthma, you are going to be in a good shape. Okay? And those triggers are allergens, as I mentioned before, stress, changing weather, exercise, cold air, strong emotion, as well as staying away from smoking or people who smoke. All right? That's it, guys. Thank you so much. I really appreciate. Go ahead and watch the video. Leave your comments. Anywhere that I made a mistake, I appreciate if you can point it out so that in my next video, I can make the adequate corrections. All right. Good luck in your exams and good luck with your parents. Thank you.